Thank you very much. This is Dr. Tolchin. Thank you to everyone for joining us today, and thank you to Lisa and Shannon for hosting this webinar series. So let's jump in. Today, my colleagues, Dr. Ubeda and Dr. Dubon, are going to talk to you about cerebral palsy, adaptive athletics, and inclusive healthcare. Just to get out of the way, our disclosure. So Dr. Dubon and I have current grant funding from the American Academy of Developmental Medicine and Dentistry through the National Curriculum Initiative in Developmental Medicine. We have grant funding to support the development, implementation, and assessment of a new module to teach Harvard Medical School students best practices in caring for people with disabilities. Dr. Ubeda will discuss unapproved use of commercial products and devices during her presentation, and she'll describe that to you during her presentation. And Dr. Dubon's husband has employment and stock in MedStrat, which Dr. Dubon will describe in more detail to you as well. Together, we have no relevant financial relationships with the manufacturers of any commercial products and/or providers of commercial services discussed in this presentation. So I'll be talking to you about inclusive healthcare. I'll talk about a little bit about the epidemiology of cerebral palsy and the impact of cerebral palsy on daily function for individuals and for families, and then describe strategies for providing inclusive healthcare. Following that, Dr. Ubeda will talk in more detail about cerebral palsy and multidisciplinary management, followed by Dr. Dubon, who will talk about adaptive sports. So what do I mean when I say inclusive healthcare? By inclusive, I mean healthcare that engages your patient and, where applicable, their family in making meaningful decisions about present and long-term care. This is care that is respectful, non-judgmental, and incorporates the patient's goals and desires. It is care that is practiced by treating every patient who comes through your door as equally valuable and deserving of the best possible supports and resources. It is care that is provided by clinicians who know that each patient requires unique and personal strategies to communicate, learn, and share. And every patient has perspectives and needs that deserve to be respected. Cerebral palsy. Cerebral palsy is the #1 cause of childhood disability in the United States. It is a disorder of movement and posture that results from a non-progressive lesion or injury to the immature brain. In the United States, 1 in 323 children are affected by cerebral palsy, and there are at least 8,000 new cases per year in the United States alone. Worldwide, there are 17 million people with cerebral palsy. There are multiple impacts of cerebral palsy on daily function. For example, at least 2/3 of children with cerebral palsy have movement difficulties that impact their ability to perform daily life tasks like eating, dressing, writing, or catching a ball. Most children with cerebral palsy will walk 60% independently, 10% with an aid, and 30% with a wheelchair. There are multiple impairments associated with cerebral palsy that are non-motor, and here I'll just highlight pain and sleep disorders in particular, as these are under-screened for and under-recognized, and as a result, under-treated. Also, I'll make a note here that 1 in 2 individuals with cerebral palsy are noted to have an intellectual impairment, which also impacts their ability to participate in care in the standard way that is delivered and requires our attention to making sure that we are able to communicate well and provide for the needs of this subset of the population. The other important lesson here is that some individuals with cerebral palsy will need more support than others, and you cannot assume what a patient or family needs just by looking at them or by reading their charts. So our role as clinicians is to determine what aspects of life we can best support to help every individual live their life to the fullest, able to explore, learn, communicate, and live pain-free. Smart doctors know that every child who has cerebral palsy has a unique combination of strengths and challenges, and first and foremost, they're kids. And we also know that kids have a lot to say and share, and it is our responsibility to listen to and hear our patients in whatever method they need to communicate, however they communicate, and however long it takes them to do so. And we know that kids have cerebral palsy, and so do adults. All humans change over time. And while cerebral palsy is considered a non-progressive condition, cerebral palsy takes an extra physical toll on the human body over time that results in what can feel like progression of disease as an adult. And this is important to remember and plan for throughout a child's lifespan. So for example, individuals experience premature aging from years of wear and tear on their joints, on their cardiovascular system, their dentition. Adults with cerebral palsy experience pain, fatigue, and weakness from years of their biomechanics, resulting in increased energy expenditure for basic movements. And importantly, a large proportion of adults with cerebral palsy who are ambulating independently over time lose their ability to ambulate as an adult, resulting in a new need for mobility equipment. Non-physical considerations include high rates of isolation, anxiety, and depression in the population of people with cerebral palsy. Other considerations for our adults, work accommodations that need to be made and that need to change over time, and planning for adult considerations like pregnancy. These are changes from the care for the child with cerebral palsy. Transition to adulthood also requires a consideration of a whole new host of factors, including education and the cessation of government-sponsored services at the time that an individual transitions to adulthood, housing accommodations to be made, potential consideration of guardianship. So while we don't have time to delve into all of these considerations here, it's important that you know that these considerations exist. So what are challenges in our current healthcare system to providing excellent care? Healthcare professionals lack training in care for people with disabilities. Healthcare professionals often make inaccurate assumptions about people with disabilities and their lives. Accreditation agencies such as the Joint Commission do not evaluate healthcare programs or facilities for accessibility for people with disabilities. And federal agencies typically do not have disability standards as conditions for funding. Additional consideration in the healthcare system for individuals with cerebral palsy specifically. So individuals with cerebral palsy utilize healthcare resources and at least twice as often as individuals without cerebral palsy. And a recent survey of hospital staff, and this is staff sensitive to wanting to and knowing that they should engage with all patients as best they can, demonstrated some common concerns regarding communication with patients with cerebral palsy in the hospital. So one staff person said, "It can be frustrating for them and for us. I can relate to a boy on a ward that I actually looked after. Communicating was very, very hard, and he got very, very frustrated. He did a lot of signing, and we couldn't understand the signs. And then when he tried to speak to us, he just got more frustrated and started raising his voice because we couldn't understand." Another staff member said, "Yes, it has been a priority, but out of all the children who have been hospitalized, those that are nonverbal don't always take their devices to the hospital with them. It's that we're here for a medical thing and that this is a therapy thing. It's for use in therapy and for use in school. It's not a holistic part of the child often." So it reminds us to inquire about communication devices and make sure communication is optimized for every patient when we start to engage them in healthcare. So what is the impact of these challenges in healthcare delivery? Well, first, due to underscreening and management for common health conditions, individuals with cerebral palsy have poorer outcomes than their counterparts in the population. For example, adults with cerebral palsy have statistically significantly higher rates of chronic disease, including diabetes, asthma, hypertension, stroke, emphysema, and arthritis. There's decreased engagement in care with a system that may not always listen to or include them effectively in their healthcare models. And ultimately, all of these factors result in substantial patient and family suffering, emotional and physical. So what can we do to better care for our patients with disabilities and their families, our patients who have cerebral palsy, but all patients who have disabilities? We need to work within our systems to provide excellent care, model the type of care that our patients should expect and seek, and educate our colleagues to do the same, both by our example and by direct teaching. So I'm going to give you 6 tips to think about. And your presenters tonight are physical medicine and rehabilitation doctors, so we prescribe a lot of physical therapy. And one thing we guide our patients about is that the role of physical therapy is to teach strategies and techniques that the patient then needs to practice at home daily to get very good at them and for them to have a positive effect. So same here, thinking about these tips during our session is a really important starting point. And we really ask that you explore and practice these strategies on a regular basis to get good and continue to ask questions and to learn how to care for people with disabilities to sharpen your expertise over time. So number 1, provide respect. Sit at eye level and make direct eye contact with your patients. Speak directly to your patient. Speak to kids as kids and speak to adults as adults. Obtain permission from your patients where possible to include their caregivers in the conversation and offer private visits where appropriate. For example, a teenager who might like to have a private conversation with their doctor. Sometimes when there's a parent or caregiver in the room, it's easy to forget that we need to focus on the patient. Use preferred language, people first. So a person who uses a wheelchair, not a wheelchair-bound person or a person confined to a wheelchair. And don't write descriptions of your patients in your notes like unfortunate wheelchair-bound young man, because our patients read our notes and so do our colleagues. Language like that is distancing and judgmental, and it engenders pity rather than possibility. A colleague of mine uses this quote from Mark Twain in this context a lot. The difference between the right word and the almost right word is the difference between lightning and the lightning bug. These are worlds apart, just like the way that's what might seem subtle in your language choice can make a big difference for your patients and their care. Number 2, engage the patient and family in every encounter. Encourage autonomy. To the greatest extent possible, ask the patient how they prefer to be transferred and examined and when they want to be examined. Ask the patient or the family, if need be, to direct transfers and step by step if possible. Ask the patient's preferences for exams and for healthcare decisions. Empower patients to participate in their healthcare decisions. In a patient-doctor encounter, it's not just the doctor making decisions for the patient. It's the doctor and the patient and family trying to make the best decisions together, and it's important that we remember that. Revisit advanced care planning preferences often, remembering that preferences and needs change over time. Screen for abuse and neglect. This is important. Clinicians are mandated reporters of abuse of people with disabilities as a specifically protected group, and every state has a special hotline for reporting concerns or asking questions. There are a number of ways, unfortunately, that people with disabilities, and particularly with intellectual and developmental disabilities, are taken advantage of. You can see this list here, but in particular, withholding of medications, transportation, equipment, and personal assistance services are unique ways that people with disabilities are abused. Number 4, encourage health promotion. So start with the assumption that all of our patients to some degree can participate in the promotion of their own health and the avoidance of preventable complications. So the middle picture here is an adaptive bicycle and our Spalding Adaptive Sports Program. On the left, that image is to remind us that there are standards for physical activity for all people in the United States, as well as guidelines for modifications for people with disabilities. But we really encourage that everybody participate in some form of physical activity to the greatest extent possible. The picture on the right reminds us that our patients with cerebral palsy, people with cerebral palsy, just like anyone in the population, can smoke, and people do smoke, and it's important to engage them in quitting dangerous behaviors. And I like this image too because it reminds us that people with disabilities are infrequently included in health promotion materials. So it makes it really important for us to engage in public health kinds of conversations with our patients, because the public health promotional materials will not necessarily resonate with them. Number 5, assess and address office accessibility. So this includes making sure that you have appropriate equipment, accessible information materials in large print, in electronic formats, in Braille, available interpreters, that you have an educated front staff interacting with patients. This is your front line. So as the clinician, there are multiple interactions with families that happen before you see your patient. So your front staff needs to be familiar with the kinds of questions patients and families may ask. They need the skills to obtain information about accommodation needs prior to patient visits. So ask some questions about space in the office. You might need interpreters so that when the patient arrives, they can participate in their visit instead of being turned back home to come back another time when the accommodations are available. And make sure your front desk staff has permission to seek assistance from you, to say, I don't know how to do this, I need your help. And particularly for the medical and dental students out there, this might seem really far away, having your own office and directing your own staff, but it's not that far away. And also you'll be participating in clinics where you will have the ability to talk with your attendings and supervisors and staff about some of these changes. It's also important to get feedback from people with disabilities. They're the real stakeholders in their care, and to incorporate that feedback in improving your clinical care and clinic spaces. This is a really busy slide, but ultimately to say this is available on the internet. The U.S. Access Board proposes standards for accessible medical equipment. So this top picture is an examination chair, relevant particularly to our dentists and dental students out there. And there are also very clear specific guidelines about accessible examination and other equipment, and you can look these up if you're interested in learning more. And finally, in addition to your front desk staff, all the staff in a clinic should be educated about how to take care of our patients, particularly those with mobility and communication impairments, how to use special equipment, how to perform safe transfer and positioning techniques, and how to provide sensitive, non-discriminatory communication. There are high rates of staff turnover in some clinics, so this education needs to be ongoing rather than just one time. And finally, number 6, educate yourself so you can educate your patients and families. The disability civil rights movement has paralleled the other civil rights movements in our country, and improvements in access to society, which includes education and medical care today, stemmed in large part from the fight by disability advocates for equitable treatment and access. So as you learn about these features, you can share them with your patients and empower them to be a part of positive change as well. This is a really nice book about the disability civil rights movement that I do recommend, and there are more out there. Educating yourself about advocacy organizations and how to get trained to do an even better job in caring for your patients. So important here is that you can't know everything. And what is really important is that you demonstrate humility, be honest with yourself about what you don't know, and learn what you can in order to help your patients. Be honest and tell your patients when you don't know something, and show them that you're partnering with them and you're learning together. We all have a lot on our plates, and it's really important for both patients and families, along with their clinicians, to all learn together so we can do the best for everyone together. Community participation. There are many resources in many communities that allow our patients with cerebral palsy to participate fully, and it's important that we ask our colleagues and learn as much about these as we can so that we can share these with the families who we come in contact with as well. The last that I'll mention is emergency planning. There are emergency preparedness documents and questionnaires that we can attend to together to make sure that individuals, particularly with the greatest communication and mobility needs, are prepared in the case of emergency for how to move from one location to another, or how to communicate their needs in the event of an emergency. And there are a host of considerations that some of the families listening in tonight may also be familiar with that can occur during travel, loss and damage to equipment, among others. And there are nice resources available as well that can provide some guidance and resources for addressing those considerations. So that will draw to the end of my piece about the inclusive healthcare, and I'd like to turn it over now to Dr. Ubeda to talk in more detail about cerebral palsy. Thank you.
Everybody, thank you for joining us on the webinar tonight. I would like to thank the Association of Academic Physiatrists and the American Academy of Developmental Medicine and Dentistry for inviting us to participate in this webinar. Oops, I'm having trouble here. Oh. Okay, so let's start with the definition of cerebral palsy. Cerebral palsy will look very different depending on the patient we're looking at, but they all have in common a couple of things. One is that there's a non-progressive brain injury on an immature brain. This means that the injury is produced somewhere between pregnancy, the perinatal period, and the 2-3 first years of life. And this is going to be a cause of a disorder of movement and posture. Even though it's a non-progressive lesion, sometimes the symptoms that we're going to see in these patients can change over time because of the brain maturation itself and the complications we see. There's a variety of causes of cerebral palsy, and depending on the period where the injury is affected on the brain, we're going to have different causes of the brain injury. The prenatal period is the most susceptible or fragile period where we find most of the causes of cerebral palsy. Between 70 to 80% of the patients with cerebral palsy have their injury during this period. A lot of times it's an idiopathic origin, so we don't really know what happened for them to develop the cerebral palsy. But there is other causes such as infections, placental complications, socioeconomic factors, hypoxic ischemic encephalopathy that would contribute to cerebral palsy in this period. During the perinatal period, prematurity is going to be the most frequent cause of cerebral palsy in kids. Hypobilirubinemia, as you see on the list, it will be cause of movement disorders, as we'll see further on in the slides. And during the postnatal period, we can see trauma that can be accidental or non-accidental, strokes, infection, anoxia, and intracranial hemorrhage. What types of cerebral palsy are there? There's different ways of classifying cerebral palsy. One of them is depending on the area of the brain that has been affected. So if it's been the cortex that has been affected, we will see spasticity. This means that we'll be seeing stiff muscles, and this will occur in about 75% of the patients with cerebral palsy. What we will see is that certain muscles are what we call on all the time, so they're continuously contracted, and others are off. And the ability of the brain to regulate the balance between contraction and relaxation is lost. If the basal ganglia is affected, movement control is altered. And this is seen a lot in patients with kernicterus. If the cerebellum is affected, we'll see alterations in the balance and coordination, such as ataxia. Sometimes we'll see nystagmus as well. It is pretty frequent that there is a combination of areas affected in the brain, so the presentation of cerebral palsy kids might present with the different symptoms we've mentioned before. We can also classify cerebral palsy depending on what parts of the body are affected. So if we see spastic diplegia, that means that both legs are affected and they will tend to be stiff. This is mostly seen in patients who've had prematurity. Other patients will only have one side of the body affected, and this is seen in patients with stroke. Other patients will have the entire body affected, where all extremities will be affected, normally with stiffness or dystonia. And a lot of times the core can be weak as well. So like we said, cerebral palsy can present in different ways, and I just wanted to share some videos with you so you can see what movement in cerebral palsy might look like. And I'm going to try and play this video. Let's see. So this is a patient with spastic diplegia who's in a gait analysis lab. So his movement is very stiff, as you can see, in all his joints. And then on the right, you have a little girl with hypotonic cerebral palsy. That means her muscle tone is low. And she also has trouble controlling her movement. And she's using her trunk to be able to walk with her walker. What other comorbidities can we see in the cerebral palsy patient population? Well, we do. It is caused by a brain injury, and in any case that there is an injury to the brain, there's a higher risk of having a seizure disorder or a seizure at any given time. We are also going to see tone abnormalities, and this can be in the form of high tone or spasticity, like we mentioned before, where muscles can be stiff. We can see dystonia, where we're having trouble controlling the movements and the muscles we're using. And we can also have weakness. Some of the muscles aren't going to have a normal strength. So if you think about this around your ankle, and you have high tone in your calf muscle, and you have a weak tibialis anterior, which is the muscle that lifts up your toes during the gait cycle, this will cause you to trip over your toes while you're walking, for example. We also have musculoskeletal abnormalities, which can present on their own or secondary to some of the tone abnormalities we see. So hip dysplasia means that the hip doesn't develop normally, and this can be due to the muscles pulling with different strengths on different parts of the joint. So as you can see in the X-ray up here to the right, the hip can come out of place and will require surgery for management. Scoliosis can also occur due to the different tones, different muscle strengths and tone on both sides of your spine. And then bone mineral density disorders are pretty common in these patients for a variety of reasons. One, they might have nutritional deficits. Two, they have decreased weight bearing. So weight bearing helps with mineral density of the bones, and a lot of these patients aren't able to stand. Cognitive impairments are relatively frequent in this patient population. Like Dr. Tolchin mentioned before, about 50% of our patients are going to have some kind of a cognitive impairment. 25% of those are going to be severely impaired. The more severely affected the patient is in terms of the brain injury, the more likely the patient is to have a cognitive impairment. We're also going to see emotional and behavioral issues in this patient population. Autism is relatively frequent, attention deficit disorders, and sleeping disorders, like what was mentioned previously. Other comorbidities are going to be visual impairments. Strabismus is the most common one. Nystagmus in cerebellar types of cerebral palsy. Hearing impairments mostly are going to be sensory neural. They're going to be very frequent in patients with kernicterus. Both the visual and the hearing impairments are going to affect how these patients develop normally over time. Oromotor impairment is how they control the muscles in their mouth and their throats. So this is going to affect secretion management. So a lot of these patients might be drooling a lot of the time, or others might have trouble swallowing and have aspiration events. Nutritional disorder, both because they have a decreased oral intake or because they're aspirating, their nutrition might not be optimized. And respiratory disorders, especially in patients with prematurity or patients who are aspirating a lot, they will have a lot of respiratory disorders. So how do we figure out this patient has cerebral palsy? They normally present with developmental milestones and delays, whether that is motor or cognitive speech. That's how the evaluation process for these patients normally starts. So as we have seen up until now, cerebral palsy can vary a lot from one patient to the next. So we needed a common language to be able to communicate between healthcare providers, with therapists, and with parents in order to establish healthcare goals and therapies. So one of the classifications we came up with is the gross motor functional scale, which classifies the patients from 1 to 5, depending on how much support they need to be able to get from point A to point B. So in level 1, the patient walks without limitations in any given terrain. And level 5, the patient is completely dependent for all types of mobility. The World Health Organization ICF classification provides us with a framework to understand disability, not only because of the injury itself, because the injury is going to affect the body function and structure. It's also the degree of disability is also going to depend on environmental and personal factors, as well as limitations in activity and participation in activities of daily living. And when we apply this to the cerebral palsy patients, cerebral palsy is going to cause alterations in their tone and their ability to walk and be mobile, and cause weakness as well. And this is going to limit their ability to get from point A to point B, participate in activities of daily living such as toileting or dressing. And this is going to limit their involvement at activities at home. So for example, they have feeding difficulties or are not able to feed themselves at home. That might limit the time that they spend with their family at the table, school, community, or family peers. Then there's going to be a number of environmental factors that are going to limit how much the patient is going to be able to do in terms of accessibility, like we mentioned before, support or peer attitudes. And then there's personal factors that are going to be very important in this patient population in terms of what they are able to achieve in terms of motivation, if there's any safety concerns, priorities and goals, and maturation, and how mature these patients are. So when we're taking care of CP, it actually takes a village, because as we've seen, they're very complex patients with different needs. So they're going to have a multitude of healthcare providers. They're going to have a multitude of therapists. We're going to have the family, the personal care assistants, the teachers, and the schools that are all going to contribute to take care of this fragile patient population. And I have a friend who defines being a rehab doctor as being a functionologist. We want to help our patients achieve their maximum potential. So we kind of look at what goals or how we can improve mobility, getting from point A to point B, independence, being able to do that on their own, improve their ability to do activities of daily living, whether that's toileting or dressing themselves, communication, or feeding. And in rehab in particular, we have a family-centered approach to care, and That means that the way we plan, deliver healthcare and the goals that are set for the patient comes from a consensus between the healthcare providers, the family, and the patient themselves. So everybody's included in this decision-making tree. So we have a number of different resources we can use for this patient population to improve their symptoms and maximize their independence. I'm going to go from the least invasive to the most invasive resources we have. So in terms of tone management, in terms of medication, we can try and work on their tone so it doesn't affect how they move or their joint alignment, for example. We can use oral medication for spasticity. That's mostly, that's baclofen in most cases. We can also do targeted injections in the muscles that are spastic to decrease the muscle tone, and we can use Botox to do that. We can also inject the nerves to also relax certain muscles with phenol. And then there's medication that's a little bit different for dystonia. We can also work on secretion management to improve the drooling, which can be very worrisome to some of the parents, especially. And also patients are aspirating. Decreasing the drooling might be helpful. Bowel programs, a lot of patients are constipated, so having them in a good bowel program is helpful, and it also affects anything that irritates these patients is going to increase their tone, and constipation is one of those big red flags that we should treat. Sleep is also going to be a big issue in these patients, so using melatonin, sometimes clonidine, trazodone is helpful. We're also going to use bracing, whether it's to provide the joints with adequate support and to keep them well aligned, or to make the hand or foot more functional. It can also increase the endurance of the patients because, for example, braces for the ankles, AFOs, might increase the endurance of patients just because these abnormal gait patterns require a lot of energy expenditure that braces help decrease. In terms of equipment, we will look for equipment for transportation, such as wheelchairs, and for positioning, and this can be a stander, it can be an activity chair to help provide support for these patients. And then in terms of therapies can be provided in different settings. These can be provided in IEP and early intervention programs when the patients are under 3 years of age. This is provided by the state. Once they have turned 3 years, the school system is responsible for providing them with therapies. The therapies that are provided are only to be able to navigate the school environment safely. If we have clinical objectives for these patients, they will be going to outpatient clinical facilities to receive these types of therapies. So when we send them to physical therapy, we'll be working on gross motor function. So that means gait, transfers, and a lot of times equipment evaluation. We have technology that helps us also with therapy in these patients. And this is a Locomat, which helps with gait retraining in patients who have abnormal gait patterns. We also have occupational therapy that works more on upper extremity. They work on fine motor skills, activities of daily living like feeding, dressing, undressing, toileting. They can also sometimes help with cognition. Other therapies we can use is speech therapy to support communication, both verbal and nonverbal, and cognitive therapies as well. Vision therapy is like physical therapy for the eyes. We use it for accommodation difficulties, lazy eye, or processing impairments that these patients might have. And then feeding therapies to work on oral motor skills to try and decrease swallowing disorders. And then lastly, the more aggressive interventions we have is surgery that we will provide for patients with scoliosis who are developing progressively worsening curvatures. patients who've developed hip dysplasia to be able to provide adequate positioning and to try and preserve gait function. They will do surgery on the hip dysplasia, tendon lengthening to preserve range of movement around certain joints. This can be done, for example, on the hamstrings for the knees, or hip adductors for patients who have like trouble separating their legs for toileting or dressing and undressing, and G-tube placements if patients are aspirating or requires nutritional support. Thank you very much. It's now Dr. Dubon who will be continuing the webinar.
Hi everyone, can you hear me okay? All right, so I'm gonna just talk a little briefly about athletes with disabilities, and with a little mention of athletes particularly with cerebral palsy, as that's our big topic for today. So when thinking about athletes with disabilities, I think there's a couple things that I want everyone to take away from this. First of which is that there's two big categories that we think of with disability-specific sports. So there's para and adaptive athletics. Para sport or para athletics referring to athletics in parallel to the general population. And so these are sports that are either adapted for individuals with physical or sensory disabilities, or they're sports that are created just for people with disabilities. So an example of that would be something like goalball, which is specific to individuals with blindness or low vision. So the other category that we think about is category that Special Olympics really has a big stake in, and that's athletics for individuals with intellectual disabilities. And I think something I run into a lot is just confusion between the two different types of sport and the two different organizations, which are both excellent organizations, but with slightly different focus and slightly different emphasis. It's important to note that, as we talked about earlier, individuals with cerebral palsy may or may not have intellectual disability. So some of the folks may be great candidates for something like Special Olympics. Some of the folks might be great candidates for something like a para or adaptive sport. But the main thing I want everyone to take away from is that really everyone can participate in sport and athletics, and exercise is healthy for everybody. So there's always a way to adapt things to get people involved. The other thing to note, as Dr. Ubeda pointed out earlier, is there's a classification scale, the GMFCS that she mentioned, where folks are classified based on their level of function. And so some individuals with cerebral palsy GMFCS level 1 might not actually even know that they have cerebral palsy, truthfully, or they might know and they might be able to participate in sports that are for the general population and might not need a specific sporting organization that works specifically with individuals with disabilities. So as with everything that we do from a rehabilitation standpoint, sports is something that's unique to the individual. They have to be doing something that they love, that they enjoy, that they're getting a good experience out of. And I just wanted everyone to know those two different types, like subcategories, but then also the third option of some individuals may participate with just general population sports. So next, there we go. So as I mentioned earlier, or actually Dr. Tolchin mentioned earlier, I do have some disclosures. One is that grant funding that Dr. Tolchin and I have together with the National Curriculum Initiative in Developmental Medicine, which is also affiliated with Special Olympics, CDC, and the American Academy of Developmental Medicine and Dentistry. And that's looking at medical education initiatives teaching about disability. And then also just to mention that my husband does some employment ownership and stock in a company that does medical imaging. So again, para-adaptive athletics, I use the term para because that's actually the term that is recently the more preferred term, because that is an umbrella term for these types of athletics that I was mentioning before that may include adaptive sports, which are sports adapted from sports from the general population, like something like wheelchair basketball, which is adapted from basketball, or para may also include those sports like goalball that's specific to the individuals with disabilities. So obviously, well, not everybody winds up at the most elite level, but usually what people know the most about para sports is the Paralympics, which is at the Olympic elite level. And so this video is something that I always find it's really helpful to show, because it's showing how amazingly competitive, amazingly athletic these athletes are, and just shows a wide variety of the different sports. So this is actually from a UK commercial for the Rio Paralympic Games, and I think it just demonstrates a lot of the summer sports really well. So I'm going to go ahead and play that.
Yes, I can, suddenly, yes, I can. Gee, I'm afraid to go on as turned into.
So this is some wheelchair
yes,
racing.
Can. Take a look, what do you see? 133 pounds of confidence. Got the feeling I can do anything. Yes, I can. Something that sings in my blood is telling me, yes, I can. I was just born today, I can go all the way, yes, I can.
So you saw a little bit of the wheelchair rugby right before this, and obviously they're demonstrating not just sports, but other types of athletic recreation and athletic activities, such as dance and music. Swimming. Fencing.
Yes, I can. 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 Hey, yes, I can.
No, you can't.
Yes, I can! Are you ready? I can climb Everest. Yes, I can. I can fight here all night and never rest. Yes, I can. I was just born today. I can go all the way. Yes!
So this is not an official sport. And not necessarily from a safety perspective, that last one, that's something I would recommend, but I'm just going to show all the different options that are available. And those are just for Paralympic the summer sports, but there's certainly more as well. So I just wanted to kind of give you guys a variety of different types of adaptive sports that are there and available. But also what I love about that video is it's just showing people with different disabilities, and granted, obviously not all with cerebral palsy, but just different people with different disabilities out in the community doing lots of things. So wanted to transition next to show you a little bit of sports for individuals with intellectual disabilities. Now, Paralympic Games, there are certain sports that individuals with intellectual disabilities can actually qualify for. Commonly, when we think about sports for individuals with intellectual developmental disabilities, we think about this, huge organization, which is a wonderful organization, that's Special Olympics. And so I wanted to show a video of Special Olympic sports as well. This video is actually a recap of the USA Games from a couple years ago that were in Seattle. And I just think speaks volumes to how impressively awesome these athletes are in terms of their athleticism, and then also just showing the camaraderie and just the wonderful social network that's there as well.
I am not a stranger to the dark. Hide away, they say, 'cause we don't want your broken parts. I've learned to be ashamed of all my scars. Run away, they say, no one will love you as you are.
I'm asking you, athletes, to show the world what it looks like to lead from the heart. Franny, do you have a message for all the athletes?
I love you. Look out, 'cause here I come. And I'm marching on to the beat of drum. I just want to make my family proud.
I feel so happy to compete with a group of guys that I love.
They said I would never walk, jump, or run. I just proved them all wrong.
You did good.
Thank you. You as well.
We are fighting through the barricades.
So you could see the wide variety of sports available to these athletes, including the weightlifting, the track, football. Gymnastics.
No matter what your disability is, you can compete, and if you train as hard as you have, you can win gold just like I did.
I am brave, I am bruised, I am who I'm meant to be. This is me.
All right, so that is the last slide that I have. I just wanted to kind of finish up by saying that, obviously, thank you guys so much for tuning in and listening. For the med students that are listening in and are interested in working with individuals with disabilities, I would strongly encourage you guys to get involved out in the community outside of the clinical setting, because that's when you really truly get to know your patients and get to learn about all the opportunities that are available to them. And that is going to help you with your patient care, help those patients, and then help you connect other patients to awesome opportunities like this. So thank you guys so much.
Thank you. So we have a question or two, and Lisa, do you want to go over them?
I'm sorry, I was on mute. I actually don't see the questions, so Shannon, I will go ahead and let you present them to everyone.
Okay, 1 second. If anybody has questions who's attending right now, you can put them in the question bar. But one person said, the biggest problem I face caring for an adult child with CP is finding home health aides to assist her. Do you have any suggestions? On helping with that.
Hi, this is Dorothy Tolchin. So
I'm not sure. Yeah.
What? Can you hear me?
Yeah.
So this is a huge consideration for a lot of care providers, and I wish that we had a really strong, straightforward recommendation. There have been times when our patients and families have found good health providers when they are in the hospital, actually, when there are kind staff that they've then sought to be personal caregivers for assistance in the home, but that's not a very direct or typical pathway. I wish we had a better recommendation.
Let's see. Okay. I have to admit that this, where would someone start with helping and being more aware and how to help the population? Like, where's a good part to start? Maybe I'll punt that to Dr. Dubon. I think you might have some good resources.
Okay, now I'm unmuted. Yep, so I'm guessing, just to clarify if I'm understanding the question correct, I'm guessing meaning like where would you start to kind of look for community involvement to help out with individuals with disabilities in the community?
Yeah, I think, and being more aware of things in the, yes. They said yes.
Okay, perfect. Yeah, so definitely, no, I mean, that's a great, so first of all, that's a great start. It's not like there is like one single place that I would recommend going to, but I think asking around your community is the best thing to do. If you're interested, so Special Olympics does have branches throughout the United States, so there's likely going to be a branch around you and opportunities for you to do some volunteering, even if it's just, you know, for a one-day event, or sometimes people will get involved in like being a coach or assisting being a coach for, you know, an 8-week or 10-week sport. Which would be one opportunity. Certainly, so I know that I've gotten involved in some camps that exist too, so you can look for camps for individuals with disabilities as well. There's also an organization called Best Buddies. So Best Buddies is like Big Brother, Big Sister, but it connects individuals with adults usually with intellectual developmental disabilities with mentors. So a lot of times it's connected through like colleges, but there's also, so you may actually have an opportunity through your medical school to be part of that, like with the graduate school, or there are also branches of it or similar type organizations that exist that are outside of a college environment. And so, I mean, I think some of it is actually just like Googling and asking around your community, but the first step is just an interest. And I think that I'm really excited to hear that question, because I think that that's huge, because that's going to help like the next generation of you guys like really help be so engaged with this population. So it's really awesome to hear that you guys are excited about that.
Are these slides being made available? I guess, so we had a discussion yesterday. We're going to see if we can put this up on YouTube, which we normally do. And that will be available on the AADMD channel of YouTube. So you can just, it usually takes about several weeks if we get permission to put them up, of course. Let's see. Oh, yes, we can. Dr. Tolchin said.
Yes,
okay.
We are clear from our institutions to go ahead and post on the AADMD YouTube site. I'd also like to offer a plug for students who are interested in caring for this population and the broader population of people with disabilities to participate in clinical elective clerkships, particularly those at large rehabilitation hospitals. Spalding is one of them. Have a lot of resources for their communities, like adaptive sports programs and others. So should you be interested in participating, your preceptors and clerkship directors can also directly connect you during your clerkship time with some community connections that you'd also be welcome to participate in. So definitely think broadly when you do your clinical rotations as well and ask those questions. The more interest you express, the more people will connect you with the resources you're interested in.
One thing that also, oh, Lisa you mentioned about having the Disability Pride Parade every year in Chicago and Googling like events like that. Okay, another question. I am an elementary physical education teacher, and I will have a student next year with cerebral palsy. Do you have any resources or advice for him? Dr. Or ma'am. Sorry.
But just one question. What part of the country are you in?
Okay. Let's see. New Jersey.
So, hey, this is Dr. Dubon. That's an awesome question. So there is a website called NCPAD. So it's NCHPAD. I believe it's ncpad.gov. It's a government website. It's National Council on Health and Physical Activity in People with Disabilities. And it gives some information and resources about physical activity for people with disabilities. It includes on it some videos as well. I think when thinking about physical activity for individuals with different types of disabilities, some of it's like very individualized to the person. So one thing that I had to, just in the interest of time, cut out of my talk is just precautions when we think about physical activity. Is obviously safety does come first, but there's always, again, some sort of activity that you can involve people in. So common precautions would be fall risk. So just realizing that because of balance, because of weakness, because of increased tone, fall is something that is likely. So just being careful and being safe around that. And the other thing is if someone, I'm not sure if the individual is ambulatory or not, but if someone is using a wheelchair for primary mode of mobility, their bones that they're not weight bearing on can get more weak, and so increased risk of fracture. So just being careful around that to not have too much impact on those limbs. And then another one is if they have seizures, just being aware of the seizure plan and having safety measures around that, particularly if it's involving anything with a pool. But I'm happy, they're gonna share our contact information. I'm happy to speak more offline about that. And there's definitely, again, the NCPAD website would be a good one, but other resources that I can share.
Thank you. There's several people saying thank you for presenting, and that's the end of the questions. So thank you for all who attended, and Dr. Channon said thank you for presenting, great webinar team. Thank you, Dr. Channon. So thank you presenters so much for being willing, and we'll see if we can put this on YouTube so we can send it to other medical students and students who are probably studying for boards and probably forgot to attend. So thank you again, and hope you guys have a great night.
Thank you, everybody.
Thank you.